Good afternoon. Thank you for joining today's NILE webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. In case of communication breakdown or that we get disconnected, please call right back and we will continue from where we left off. Also, please locate the chat box in the bottom left-hand corner of your screen. If you have any questions, type them in the chat box and we will address those questions throughout and at the end of the presentation. Secondly, if you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey in the post-webinar email. The email will be sent out by the end of today, and all CEUs will be emailed out within the next week. A little disclaimer, Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to our first speaker, Patsy Stinchfield, who is the Pediatric Nurse Practitioner and Director of Pediatric Infectious Disease Services at Children's Hospitals and Clinics of Minnesota, one of the largest pediatric hospital systems in the U.S. She is a nationally recognized infectious disease specialist, having served as the first nurse voting member of the CDC's Advisory Committee on Immunization Practices, or the ACIP, and remains an active liaison member today. Thank you for joining us, Patsy.
Well, thank you so much for the invitation. Hello, everybody from Minnesota. I hope you're having nice weather there. We're having a beautiful Minnesota summer today. So we are going to talk about preventing meningococcal meningitis, and I'm going to cover some of the clinical aspects related to it. If you are on Twitter, there is my Twitter handle, and you're welcome to send a note to me that way as well. So here's some of the things that we're going to talk about. We're going to go over some of the clinical signs related to meningococcal meningitis and sepsis and review the meningococcal epidemiology. We're going to talk about the difference between MenACWY and MenB vaccines and why it's important to know the difference, to recommend them both, stock them both, and administer them both. So those are the things we will review. And then I'm going to just end with what we at Children's Minnesota have done in terms of incorporating various meningococcal ACIP recommendations into our practice here. So starting with Neisseria meningitidis, I think most of you on the call know what a terrifying and difficult bacterial infection this is. And those of you who work in health systems know that people who have seen meningococcal meningitis never forget it, and they can spot it relatively quickly afterwards. And it's this purpura, these purpley hemorrhagic lesions that tend to be the telltale signs. They're difficult to see sometimes in dark-colored skin in children of color and can sometimes even be missed. They're often a later sign, however, and the earlier you can notice this type of meningococcal rash, the better. It's interesting working in a children's hospital and trying to encourage my teams to protect themselves against influenza and pertussis and meninge by wearing the proper PPE. When there's somebody with influenza coming in, our teams tend to be like, oh, I've worked here 25 years, I don't have to wear a mask, it's fine. But when a child comes in and somebody wonders if it's Neisseria meningitidis, people run for their personal protective equipment, and it's because they have seen how devastating this disease can be. And for them as clinicians, it actually is a scary situation because things change so rapidly. So I borrowed this slide from Dr. Amanda Cohn, who is the Executive Director of the ACIP, and I heard her give an excellent talk at the National Foundation for Infectious Disease Clinical Vaccinology course late last year in 2017. And by the way, if you've not attended NFID's course, do sign up for it because it's an in-depth, wonderful vaccine course, and I'm going to disclose that I'm on the Education Planning Committee for that group too. But Dr. Cohn used this slide in her meningitis presentation, and I thought it was so helpful. It's very cellular, as you can see here, but it helps, I think, describe why we have two different vaccines and why they can't be kind of rolled into one. I think there's a lot of confusion amongst clinicians, and it's our job to explain it to parents, and if we as clinicians are confused, parents will be confused. So let's see if I can get my little arrow to work here. If you look at the capsule, the polysaccharide capsule, that's where our serogroups A, B, C, W, X, and Y, and they can cause the most disease globally, and that is the target for the conjugate vaccines. Whereas the outer membrane is where the targets for the serogroup B vaccines are. And so in developing vaccines, and I'm not a vaccine developer or researcher here, but just in my understanding through my years at the ACIP, you're really looking at, what part of that organism can you use as your target to try to develop and grow and create into a vaccine. And the serogroups are on different parts of the organism. And so as you look at the complexity of this with the outer membrane and the various plasmic areas, that these serogroups do originate from different parts of the bacteria. So they're actually, from the very beginning, are targeting different types of Neisseria meningitis, and they're going to work against different serotypes. And that's why they're not interchangeable. That's why they can't be combined into one vaccine or things that seem kind of simple. This is a very complex bacteria, and the way that the vaccines were developed also follows along on that complexity. So in terms of this disease, how is it transmitted? It is transmitted person to person, and it is direct contact with saliva. And in healthcare settings, it really needs to be very direct, so mouth to mouth without any protection. Intubation with very direct exposure. We'll sometimes have a child come in with meningococcal meningitis, and people get really nervous about, I was in the room, or I brought in some supplies, or I took the child's vital signs or whatever. We would not consider that an exposure and would not put them on post-exposure prophylaxis, oral rifampin. But if someone did do very intimate, difficult intubation, for example, and we're down pretty close face-to-face, we would consider that an exposure and would prophylax them. Once you are exposed, the incubation period is 3 to 4 days. The range can be as short as 1 day. And so in adolescents, for example, sharing of water bottles or kissing or sharing straws or things like that, essentially the exchange of saliva and as short as a day later can develop symptoms up to 10 days afterwards. But typically it's about 3 to 4 days. So what happens after that is, and this is one of the most unfortunate parts about this disease, is that a sort of common flu-like presentation happens. Somebody develops a headache, they feel a little yicky, a little nauseated, vomiting, they might have fever or loss of appetite. And because that is so common with so many viral illnesses and other early signs of bacterial illnesses, it can be overlooked. But that is the critical moment is to try to seek help as soon as possible. Within 12 to 15 hours, this purpuric or that purpley hemorrhagic type rash will develop, a stiff neck, and photophobia, or painful eyes, that light is bothering the person's eyes. It's oftentimes that the combination of flu-like symptoms, and sometimes people even go in, get checked, and are told, well, you've got viral syndrome, you've got the flu, you've got influenza, and sent home. And then the rash develops in stiff neck, and then they are often brought back directly to the emergency room. very rapid progression to shock-like collapse. And this is what is so terrifying about this disease. And for clinicians, they know that the clock is ticking in the management of children and adolescents and adults with this disease. Very quickly, the meningismus can develop, so the stiff neck, bacteremia where there's blood infections. There can be pneumonia in otherwise healthy young adults can be common. The potential for death within 24 hours. And so there are not a lot of infectious diseases that are this rapid and this dramatic and with this high of a case fatality rate, which can be 10 to 15%, and then permanent sequelae up to about 20%. So loss of limbs, permanent brain damage, vision loss, hearing loss, other kidney abnormalities and things like that. So it can be quite a devastating disease in many, many ways. So there can be a various clinical spectrum. So in about half the cases, up to half the cases, 30 to 50% will have meningitis alone. In about 7 to 10%, they will have blood infection or septicemia alone without a meningitis. And about 40% will have both septicemia and meningitis. And then other clinical syndromes can include pneumonia, arthritis, peritonitis, and conjunctivitis. So let's just talk a little bit now about the epidemiology. And this is a slide you can get from the Center for Disease Control as you think about this. And when you look at the meningococcal disease incidence from 1970 to 2016, which is the latest year that we have data available, and this is through our national disease surveillance system, the rate per 100,000 is, back in 1970, somewhere between 1 and 1.5 cases per 100,000. And you can see dropping down to 2016, far below 0.5 per 100,000. So how does that compare? If you take another disease and you look at something like pertussis can be anywhere, it varies by state, and it certainly varies by year, but it can be anywhere between 3 cases per 100,000 individuals up to 27 cases per 100,000, and so much more common than meningococcal disease. And so that's one of the considerations about this, especially as we're deciding public policy on vaccination, is it is rare. It is a rare disease compared to other infectious diseases that we have. And so, as I said, a devastating disease, but a rare disease. And those are the considerations that have to be brought to mind. Our vaccines that we introduced came in to play around 2005, and you can see a nice steady decrease since then. So when you look at this by age, there's really kind of 3 age groups that tend to be higher incidence, that those young infants has the highest, and in fact, MenB and very young infants, newborns up to 2 months, we really don't have a vaccine for that age group. And then the next bump you see there in that 15 to 19, maybe out even to the 24, 25-year-olds, and then kind of relatively flat from mid-20s to mid-70s, and then another spike up in the elderly. And so a little bit of a W epi curve there with young infants, adolescents, and then the very old. So when you look at the incidence of meningococcal disease by age group and the serogroup in the United States, and this is from when we started using the vaccine to 2014, the yellow bars are MenB, and as I said, you can see in that less than 1-year-olds that is the most common, and it's actually in very young infants is even more common. And in that age group also, you can see a big block of unknown that we're just not sure. Sometimes we're not able to identify what the actual serotype is, but quite a mix in that young age group. And then when you go back up to the other high incidence age group that say 14 to 24, you can see the increase in serogroup B in the yellow there, but quite a spread. You can see some C and Y across that age group. And then same with greater than 65 and the elders, you see more serogroup Y there. And so again, two different vaccines getting at two different types of vaccines in the way that they're made, one made with 4 serogroup types and another made with just the MenB. And so that's, again, why you want to have the different products available to prevent these at the different ages. So ACIP has recommended vaccines, the MenACWY, for routine use, given routinely at 11 to 12 years of age, and then a booster dose at 16. There is also high-risk population recommendations for certain medical conditions such as asplenia, complement deficiency, children with HIV, that they should be 2 initial doses separated by 8 weeks and then boosting them every 5 years. And then college, special populations such as college students living in dorms. And I always thought that was so specific when we were first hearing some of the studies about this vaccine. And it was really because that's who they studied. That's where the study occurred. Microbiologists and certain travelers, for example, to the meningitis belt, people going to the Hajj. I think that one of the things to think about is that it's not just college students living in dorms, but if you have somebody who is going into the military and they're going to be in closed quarters, or if you've got somebody who's going to be on, some kind of a mission trip to the Hajj and they're living in group setting. And so thinking about when you're thinking about special populations, it isn't necessarily the college part of it. It's really kind of what those living conditions are. And interestingly, less than 2% of all cases are related to outbreaks. And I think the outbreaks in colleges really get a lot of national attention. And, we've had some recently in Oregon and other states. And but meningitis outbreaks on college campuses are not the primary cause of meningitis cases. In fact, it's very sporadic. It's very unpredictable. It doesn't really have regional, locations in the country that have more outbreaks than other. You can have an East Coast and then a West Coast college that pops up, and then a Southern university. And so it's very, very hard to predict, both for individual cases and in outbreaks. So the ACIP recommendation is dose 1 is given between around 13 to 15, with a second dose at 16 to 18. If dose 1 doesn't need a booster, if it was received on or after the 16th birthday. So if you're getting your first dose at 16, that's all you need. So let's talk a minute about ACIP MenB recommendations. This has probably gotten a little bit more conversation and confusion because I would say it's one of our more softer recommendations. Category B is what, there's 2 kinds of categories on the ACIP recommendations. Category A is everybody gets it. If it goes on the schedule and you're 2 months old, you're going to get that DTaP. That's a Category A recommendation. Whereas Category B is permissive, and basically it's a conversation with the clinician that you talk over what are the risks for this individual and what's the potential for them to have meningococcal meningitis. And as I just said, it's very hard to predict, where, and the cases are so sporadic that, determining an individual person's risk, I think, is really quite difficult. There are a couple of brands for MenB vaccine. The CDC did not make a preference in our ACIP recommendations. So I'm saying the brand names here just for clarity, not for promotion, but that Trememba is made by Pfizer, and it has 2 components, and it's given at 2 doses at 0 and 6 months, or they also have a 3-dose series at 0, 1 to 2 months, and then 6 months. GSK makes a product called Bexsero. It has 4 components in it, and it's 2 doses at 0 and 1 month. These both are licensed for ages 10 to 25 years. Most people are giving the doses somewhere between 16 and 18. They both have excellent safety profiles with the typical, what you would expect with vaccines, pain at the injection site, some fatigue, some muscle pain, and things like that, nothing out of the ordinary. And they both have very few contraindications, and it's the standard if you've had an allergic reaction to your first dose, then the second dose would be contraindicated, or at least precaution where you need to think about how severe was the reaction to it. So let me just talk a little bit about when we got these permissive recommendations at Children's, and we had to decide how do we implement them. Here's what we're dealing with. So we have 2 hospitals, and they both have both hospitals in St. Paul and Minneapolis, Minnesota, have large outpatient clinics, primary care clinics, and most of our folks that come to our hospital-based clinics are on medical assistance. And then we've got 12 general pediatric clinics scattered throughout the metro area. They're more suburban. They tend to have more of a mix of insurance, et cetera. And then we have 11 specialty care clinics. We translated 51 languages in our system last year, and we're spread out amongst a 20-mile radius. And so we have a lot of clinicians that we need to teach. It's very important to us to practice as one system, even though we're lots of different smaller clinics, and that families get the same advice and the same treatment. So what we have developed is a vaccine review committee. So when the ACIP and AAP make recommendations, we take them here at Children's and go through our vaccine review. And in the case of MenB, when we had 2 available options, I have hired a vaccine specialist who's worked with us for a few years, and he has a master's in public health and just did a very nice job in doing a side-by-side comparison. We take it to the committee and we reviewed, for example, is there a difference in the dose size? Is there a difference in the number of doses, et cetera? Are there any considerations such as latex, or what about adverse events, or are there any more precautions of one over the other? And so then we take it to the committee and we made our decisions. So when it came to the MenB vaccine, everyone on the committee had seen a child with meningitis, and so it was very clear to us this is a disease that we don't want anybody to have. We know that it's a rare disease. The stories are heartbreaking, and we've personally taken care of patients with them. We did not feel comfortable with this, if a parent asks about meningitis B vaccine, have a conversation with them, because that feels like the information haves and have-nots, and we feel that it is important to provide the same standard of care, whether you're in inner city or out in the suburbs, whether you're going to college or going to a tech school or into the military. And so we felt like asking about their education plan seemed a little bit unscientific. And so we basically just built it into the routine and said every 16-year-old that comes in, we're going to have a conversation with all of them about MenB vaccine and try to encourage its use. So being parents of young people, we chose to encourage it. And, basically, even at the ACIP came down to, well, if you had a child who was 16, would you give it to your child? And the answer is yes. Our pause, however, because there is a little bit of what gives us pause on MenB vaccine is that it does have a short duration of protection, maybe 3 to 5 years. There's waning immunity. And we're just not sure of the impact on the carriage, which is we all walk around with various organisms in our nose, whether it's Neisseria meningitis or MRSA, staph infections, et cetera. And what is vaccinating going to do to the carriage? Does it disrupt it? Does it reduce it? And we don't really know. We don't have that science. And so, but those things aside, we did decide to go ahead and use it. And here's some data. And we do think it's important to track the amount of vaccines that you're giving, and then we give this feedback back to all of our clinicians. And so you can see we had a big push in 2017, and are continuing to give it to unique patients in 2018 who present at 16 years of age. Some of the implementation considerations we had at Children's is that I think we leaned a lot on our culture of safety, that it is our job to prevent, illness, death, disability, and do what we can. As long as ACIP has allowed us to have access to that vaccine, we felt we should use it. We stay current on ACIP recommendations with our vaccine specialists. We have clinic vaccine champions. We have our vaccine committee, and we're watching the data on MenB vaccine and its use over time. We also have a culture of every visit is a vaccine visit. So if they come into the clinic with a broken thumb, then our job is to look at their immunization schedule and fix that thumb. And if they're behind, to make sure that we vaccinate them. Teaching all the staff and ensuring that everyone's on the same page. And I'm not sure we're exactly there. There's some clinicians that are like, well, if the parent raises it, I talk about MenB, but I would say most of our clinicians do follow what we're encouraging, which is to have it as a standard of care in providing that conversation and vaccination at 16. Being very transparent with data, and then not forgetting your own high-risk staff. So all of our microbiologists here at Children's Hospital are vaccinated. So thanks for letting us share our story from Children's, where we think that children are the most amazing people on earth. Thanks.
Patsy, thank you so much for providing that clinical education portion of today's webinar. That was really interesting. I should have prefaced this NILE webinar with today's presentations are going to run a little differently than they have historically. As you just saw, we heard Patsy present on the clinical portion of meningitis, disease prevalence, and vaccination. And then I will now provide an overview of Nevada's coverage and school requirements, and then we will wrap up today's webinar with 2 survivor stories from 2 individuals who have gone through meningitis and are willing to share their stories. So this again is Brianne Van Dyne with Immunize Nevada. In addition to serving as your moderator today, I'll also be presenting some information about the meningococcal vaccine requirements for Nevada in order to give everyone an idea of sort of the vaccination landscape of our state, so to speak. I'll also be providing a brief overview of Nevada's coverage rates for the quadrivalent meningococcal conjugate vaccine. This piece of the presentation will be brief, as I know many of our participants are based in other states, or states other than Nevada, but I did think it was important to provide some Nevada-specific information as it relates to this particular antigen. So Nevada currently has meningococcal vaccine requirements in place for both our 7th grade and college freshman student populations. The Nevada State Immunization Program and Immunize Nevada collaborated last year to communicate with healthcare providers, school personnel across our 17 counties, and the general public regarding the recent change to the state's required vaccines for school enrollment. The requirements for 7th grade enrollment as of 2017 are a child enrolling in 7th grade in a Nevada public or private school after June 30th, 2017 must receive an immunization against Neisseria meningitis or meningitis in the form of a quadrivalent meningococcal conjugate vaccine, or MCV4, or MenACWY as it's now referred to. The child must receive at least one dose of MenACWY on or after age 10 years. And this new requirement does not apply to students enrolled in a Nevada public or private school prior to July 1st, 2009. The students who were in advance of 7th grade, as of this requirement coming into place, were kind of grandfathered in with their existing immunizations. Also in 2017, Nevada updated its meningococcal vaccine requirements for university freshmen. The requirements for university freshmen as of last year state that per Nevada law, unless excused because of religious belief or medical condition, a student enrolled as a freshman of a Nevada university who is less than 23 years of age upon enrollment may not attend university after September 1st, 2017 without proof of immunity to meningitis. Vaccination with at least one dose of a quadrivalent meningococcal conjugate vaccine on or after age 16 will satisfy this requirement. For the purpose of this requirement, university is defined as any university within the Nevada system of higher education or any private post-secondary educational institution. Vaccination with at least one dose of quadrivalent meningococcal conjugate vaccine on or after age 16 will satisfy this requirement. And then just because Patsy spoke to MenB as well, I just wanted to include a little side note about MenB. Many teens, Nevada included, have not received the meningococcal serotype B vaccine, or MenB, since it was only recently permissively recommended by the Centers for Disease Control and Prevention in 2015. So why the school requirement? Enforcement of immunization requirements for children entering child care facilities and school has resulted in high childhood and adolescent immunization coverage levels. Nevada previously only required the Tdap vaccine for 7th grade entry, and the quadrivalent meningococcal conjugate vaccine was recommended to be administered at the same visit. Unfortunately, national studies show that 86% of adolescent patients who were in the office for a vaccine-only visit did not receive their first dose along with other age-recommended vaccines. This requirement, or this new requirement, will help Nevada improve our immunization coverage for the quadrivalent meningococcal conjugate vaccine. Next, is this vaccine a school enrollment requirement in other states? And the short answer is yes. Almost 40 states have a secondary school or university requirement for the meningococcal vaccine, and almost all states have a secondary school requirement for Tdap. For more up-to-date immunization law information, you can visit immunizennevada.org/laws, as is indicated on this slide. In Nevada, where is the vaccine available? So we recommended adolescent vaccines, including MenACWY, can be administered by doctors' offices, pharmacists, healthcare professionals at community clinics, community health nurses, and at local health districts. Additionally, the VFC, or Nevada Vaccines for Children program, provides vaccines to children who are underinsured or uninsured, eligible for Medicaid, or Alaska Native and American Indians. So how is Nevada doing? We've made great strides as a state over the course of the last 3 years. According to the NIS teen data, Nevada's rates have grown from a coverage rate of 66% in 2014 for MenACWY to 79% in 2016. In order to try to explain our dramatic growth, I reached out to our immunization data expert at the Nevada State Immunization Program, who unfortunately wasn't able to make an on-the-spot correlation between any significant change the state implemented to account for our significant increased coverage. We would love to take credit for that, but there's just not the data that's available to support that right now. The most likely explanation may be that the sample size of the National Immunization Survey is typically small, and any small variation can cause those rates to change. That concludes my brief overview of Nevada's meningococcal vaccine requirements for school and our current coverage. Immunize Nevada and our partners at the the Nevada State Immunization Program have a great deal of state-specific information on the websites on your screen should you wish to learn more. And of course, we encourage you to visit the websites for National Meningitis Association, Immunization Action Coalition, and the CDC, as there are other excellent resources as well. And with that, I will go ahead and turn it over to our first meningitis survivor speaker, Carl, who will share his story.
Hi, thank you so much, Brianne. Excited to be here today, and I appreciate the opportunity to talk with you all about my story as a meningitis survivor. As I said, as a survivor of meningitis, I work with the National Meningitis Association, NMA, as a team advocate to kind of spread awareness about the disease, about the vaccination that you can use to prevent it, and also just about my story to kind of educate people more. I'm saying hello to you today from sunny Seattle, where it is surprisingly 90 degrees and not raining, contrary to popular opinion, so it's beautiful. When I was 14 years old, I was a freshman in high school. I was your average everyday kid, played sports year-round, tried to stay on top of schoolwork, and my biggest concern was really when my next meal was going to be, when my next sports practice was. Not really anything about my health because, at that age, nothing can harm me. But then one night I went to bed with what I thought was a really bad case of the flu. I was up all night, vomiting, just high fever, so I stayed home from school the next day and was kind of just in and out of sleeping all day, just laying on the couch. And then about 1 or 2 o'clock in the afternoon, my sister, who was home, noticed that I was starting to develop a purplish rash on my body, arms and legs, and was pretty concerned about it. So she called my parents, who rushed home and took me to our primary care doctor, who luckily for me had just been to a conference where they had discussed meningococcal meningitis and discussed the symptoms of it. And luckily he recognized it. And very quickly he was able to call the local emergency room, who rushed an ambulance over to pick me up. They brought me there and were able to complete a spinal tap and diagnose me with meningitis. And within about 2 hours, I was on a helicopter being airlifted from my small regional hospital down to Seattle Children's Hospital. About an hour-long chopper ride. On the chopper, my heart stopped twice, and they were able to resuscitate me. I ended up being in Children's Hospital for about 3 weeks in a drug-induced coma, where my heart stopped a couple more times as they tried to save me. But at that point, my organs had already started shutting down, and the gangrene had started to set in on my extremities. Luckily, I pulled through that, and they were able to wake me back up and then transfer me to our main trauma hospital in Seattle, where I'd spend the next 4 months. I had 10 surgeries, had the amputation of both my feet below the knee, as well as 3 of my fingers. And I got sick in September of 2003, and I was in the hospital until March of 2004, so about 5 months altogether. When I was finally released from the hospital, I went home. But over the next 4 years throughout high school, I was in physical therapy 3 times a week, trying to strengthen my skin grafts, strengthen my legs so I could learn to walk again. I got prosthetic legs and learned to walk. Luckily for me, I was able to stay with my class and graduated on time from high school, and went off to Gonzaga University in Spokane, where I completed my degree in civil engineering. And today I'm a civil engineer for the local power utility. Married for about 5 years. So life is good. But that's a little bit just about my story with meningitis. But I like to tell people that meningitis is the best and worst thing that ever happened to me. It's the worst because obviously I went through this terrible ordeal, but it's the best because it changed me into the person I am today, gave me a platform in which to speak to other people and to be a voice for other victims of meningitis that unfortunately did not survive like me, and their parents who mourn their loss, and their loved ones who mourn their loss. So thank you guys all for listening today and hearing my story, and I welcome any questions that you guys may come up with.
Thank you so much, Carl. That story, even when I was reading through it in advance of this presentation, just really struck a chord with me. I'm just so impressed that you still continue to graduate high school on time and have just definitely, I mean, that alone is huge, but have, like you said, definitely turned your experience into something that can be meaningful and at the very least educational for all of us and for anyone else who's fortunate enough to hear your story. So thank you.
Thank you.
We will now move on to Katelyn, who is also a survivor who has joined us today to talk about her experience with meningococcal disease. Katelyn?
Hi, yes. Hi, everybody. I'm Katelyn. I am talking to you from Nashville, Tennessee, and like everybody else, it's a really nice day outside. I'm going to do my best, although you might hear my baby babbling in the background. He is also going to be joining us. So anyway, I'm also talking to you as a meningitis survivor, and so I kind of do my best to try to tell everybody my story and get everybody out there vaccinated if I can. So anyway, okay, the first time I ever remember hearing about meningitis was when I was 18 years old. I was at the doctor's office. I was getting all my shots and vaccines, getting ready to go into college. I had to get them all because I was planning on living in a dorm at the time. So I was ready to get out of that doctor's office. My arms were sore. I was getting all my stuff ready to go, and the doctor actually looked at me and said, there's one more shot. This one is optional. So at the time, sorry, let me put my baby down real quick. At the time, I was thinking, oh my gosh, I already got so many shots. Another one, I can't even imagine. My arms hurt. I'm ready to get out of here, go hang out with my friends. So whenever I heard the term optional, I went ahead and decided that, I'm 18, I'm healthy, we're all a little indestructible at that age. So I thought, I've never even heard of meningitis. If I haven't heard of it, surely it can't be that dangerous. So I politely declined and gathered all my stuff and went ahead and went on about my life, never giving the term meningitis or the term meningitis second thought. That is until about 10 months later. I had just gone back from spring break, and I woke up that morning. I was getting ready to go to work, and I had a sore throat. I told my mom about it. She was a nurse in the ER at the time, and so she kind of watched me. Quickly, it went from a sore throat to I was vomiting about every 10 minutes, and I got a temperature of 104. My mom immediately thought the flu, just what they said earlier. She gave me some Tylenol to bring my fever down and watched my vomiting, made sure I got lots of water so I didn't dehydrate and stuff. And, we went about our day. I started feeling better, and that's when she noticed the purpura breaking out all over my skin. It started on my arms and kind of moved into my belly. And so that is really what sent off alarm bells in her head as an ER nurse. She knew that a rash, especially a purple rash, is not a good thing. So she ended up taking me into the ER that night. It was about 15 hours after I woke up that morning from a sore throat. It had already gotten to the point where I'd gone into the ER, and when I got there, my blood pressure was bottoming out, and I actually passed out twice waiting in the waiting room. So I was doing pretty poorly, right whenever I got in. They diagnosed me with bacterial meningitis the next day. And that was, honestly, that night that I got my diagnosis was the scariest night of my life. It kind of hit me then just how serious my situation was, because the doctors came in and told me what I had, and about 2 hours later my mom had to come in, and I'll never forget her standing over my bed and, telling me kind of what was going on, and that they didn't really know what was going to happen to me and stuff like that, and that if it went a way that we were all obviously hoping it wouldn't, kind of my funeral arrangements almost, basically, would I want to be buried or cremated, and if there was anything that I needed to tell anybody, and as an 18-year-old, that hits you pretty hard. So it was then that I kind of realized exactly how serious this disease was. But anyway, I made it through. I ended up spending 3 weeks overall in the hospital. During that 3 weeks, the first 2 weeks I was on continual dialysis. My kidneys is what are definitely got it the hardest. Whenever I went into the hospital, they actually had already shut down completely, and the doctors were hoping that they would be able to come back, but they never quite recovered, not back to where they were. So I got out of the hospital. I wasn't able to walk by myself. I had lost 20 pounds. I was really weak. I was on dialysis. I was in a completely different situation than I was going in. Before, I was happy, healthy. I had been a cheerleader, very active college freshman. So anyway, I was on dialysis after that for about 2 years. And during that 2 years, it was really hard. I thought back about the day in the doctor's office a lot. I was really angry. I was angry at myself. I was angry at the doctor. How could he not explain to me exactly, what the risk was? He didn't argue with me when I said no, and I was so young and, 18, you don't know what all's out there, I guess. And I was angry at myself for being so arrogant, thinking that nothing could happen to me. But anyway, it took a long time, but now obviously I've gotten past it. I'm really happy. I've learned that there is life post-meningitis. It took a really long time, but about 3 years and a month ago, I was given the most beautiful gift ever. I had a kidney transplant, so yay, no more dialysis for me. I actually got married, and I had a baby, even though they didn't think it was going to be possible after I got meningitis with my kidneys. It definitely has taken me a long time to kind of get my life back together, to accept what's happened. It's still, I find myself at times letting fear kind of creep back in, thinking it's going to happen again or something's going to get me. But I've gotten better about accepting what's happened and being able to share my story, and hopefully keeping other people from making the same mistake I did. That's what helps more than anything. So anyway. That's pretty much it.
Thank you so much, Katelyn. That is pretty much just like Carl, like the happiest ending you could hope for.
I know, that's exactly, yes.
And again, it's so important, especially to those of us who work in public health and in other healthcare professions, schools, child cares, and other facets of the public in general, just to hear the experience of people who have been directly impacted by meningococcal disease. I just think it further reiterates why we do the work that we do and why it's so important to do everything we can to promote immunization against meningitis. So thank you guys again for agreeing to share your stories.
Yeah, thank you so much for having me.
Oh, of course. Again, thank you to Patsy, Carl, and Katelyn for agreeing to speak today, and to the National Meningitis Association for coordinating this webinar. Before we say goodbye, we'd like to offer a little more time for last-minute questions. I do have a few flagged, so if you've already written those down, we will be addressing those as well. But if you have not, please type those questions in the chat box now. While we're waiting for those questions to be typed in, just a couple of reminders. If you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended, or in the post-webinar email. The email will be sent out by the end of today, and all CEUs will be mailed out within the next week. If you'd like to view or share this webinar, the recording will be available on our website along with information for future webinars and our archived past webinars as well on immunizenevada.org/webinars. And we'll have that posted within the next week or so as well. So now for questions. The first one came for Patsy, and the question was, why aren't babies and people ages 65 and over vaccinated against meningitis if we see increased incidence in those age groups?
Yeah, thanks. I saw that question, and I think it's a good one. We do have some products that can go down to 2 months of age, and that's the MenB product was studied and licensed for preventing ACWY down as young as 2 months of age. And so anyone with a high-risk condition could get it as early as 2 months of age. We tend to focus on the adolescent age group because that's where the highest incidence of death is. And that is also, we think, where that adolescents do spend time with both those other age groups, with infants and, being either as a sibling, as a babysitter, a daycare provider, et cetera, and also with their grandparents. And so like we learned with pneumococcal disease, if you can vaccinate that highest risk group, that you can have secondary impact on the other groups. For the elderly, that's tricky because you can see in that graph that really started peaking around 80 to 85 years of age. And the tricky part is that the older we get, the less functional our immune system gets, and so their ability to make antibodies and retain antibodies is just not as good as in the adolescents whose immune system tends to be more robust.
Great, thank you, Patsy. The next question was for me, and the question was, do you think MenB will eventually be required for enrollment in Nevada? This is a question that I get a lot, or would get a lot, when I would make AFIX visits for the state immunization program. And the short of the long is I don't know. So long as it's a Category B recommendation from the ACIP, and then that's, of course, adopted by the CDC. I don't know that Nevada will prioritize the recommendation of that for 7th grade enrollment. I think it also has to do, like Patsy had mentioned, with the waning immunity or immune response of the vaccine as well. Perhaps if they develop in the future a MenB vaccine that lasts a little bit longer than the 3 to 5 years that it's currently projected to last, that could possibly have an impact on Nevada's adoption of that as a requirement for school enrollment. But that's a great question as well. And the last question was for Carl. Do you know what serotype or what serogroup of meningitis you had by chance?
Yes, I had MenB. But
okay.
I was not vaccinated for any of them. I didn't have the quadrivalent, or obviously the MenB vaccine wasn't available then.
Okay, so if you couldn't hear, Carl had the MenB serogroup of meningitis, and he had not received those vaccinations for either that or the MenACWY. Any other questions or no other questions have popped up in our chat box as of now. If you have any additional questions that you think about after the webinar, please feel free to reach out to me, Brianne at immunizennevada.org, and I'm happy to look into those for you and use our resources to answer that. And that concludes today's NILE webinar. Again, thank you to Patsy, Carl, and Katelyn, and to those of you who participated today. Have a great day.